Good afternoon. I'm delighted to be able to welcome you today to our 27th annual Laverne Coleman Lectureship, highlighting critical issues in healthcare. And today, that is nursing practice in the organizational context. It's always a pleasure to have the opportunity to bring together our students, our faculty, members of the community, people from clinical agencies around these lectureships and give us an opportunity to share. We're delighted to have all of you with us today. This is my favorite lectureship because it has such an interesting history and I have a personal role in that history, so I even like it better. And for those of you who were not here back in 1984, that's when this whole idea began. And one of our doctoral graduates, Dr. Mary Lou Bond, who's now at the University of Texas at Arlington, and several of her former classmates came up with this very big idea. And that was to start a lectureship in fundraising to honor Laverne Coleman. And not only that, it was a secret, it was a surprise. So not only did they have this big idea, but they had to negotiate it and bring everything to completion without Dr. Gallman knowing. And that was harder than one might think because she was involved in every single activity that graduate students did in a good way, not in a bad. But so it was very hard to keep a secret. So Dr. Bond and several of her classmates pledged $500 each to start this process of the fundraising. They sent letters out to all the master's and doctoral students and alumni, and Jeanette Hartshorn, who was then the president of ANGS, we had ANGS back then, sent letters to all the graduate students that were currently enrolled. And I was one of those doctoral students at the time, and that was the first time I ever gave to the University of Texas at Austin, was in honor of Dr. Gallman, and not the last by any means. But what I think is so special about this lectureship is that it came from the heartfelt gratitude, appreciation, and thanks that all of the many students that passed through this university under the guidance of Dr. Gallman felt for her. They were successful in raising the sum of $26,500 to create the endowment. That was a special time. That was around our centennial as a university, and the regents were willing to match endowments, and that's what had gotten them interested in doing this. And so the regents matched it, and we had a $53,000 endowment to start with. And now, some 27 years later, it's worth approximately $236,000. Now, we don't get to spend that money, for all of you who don't know how endowments work, although the dean might like to, she doesn't get to. But what happens is that endowment is invested, and we're able to use the interest from the endowment each year to sponsor lecturers and the lectureship to come here at the University of Texas at Austin. We have traditionally tried to be sure and involve graduate students in a good number of those activities because of Dr. Gallman's leadership of the graduate students and her own commitment to that over the years. Dr. Gallman had a long and distinguished career in Texas. She is a professor emeritus of our School of Nursing. She first received her Associate of Arts degree from Kilgore College in 1943. Her career progressed, and she is an alumnus, a PhD from the University of Texas at Austin, not that other school that might be in your program. Pay no attention to that. And she came here and became a full professor subsequently in 1984, so just about the time that this endowment was started. She served in many, many capacities, and I think the key word there is service. She was always so gracious. I remember she was the first person I met when I was a prospective graduate student and was a large part of the reason that I came here. As a faculty member and now dean, actually as a student and a faculty member and dean, I've had the honor to benefit from the many outstanding lecturers that have come here to the school that have been part of this endowment. So I'm very pleased today to introduce to you the person who made this endowment possible, our Professor Emeritus and former graduate advisor, Dr. Laverne Coleman. We're so very glad that you could be with us today for this lectureship. Thank you. Now I'd like to introduce Dr. Linda Yoder, Associate Professor, who's going to introduce our distinguished speaker for today.
Good afternoon. I've interacted with Dr. Clarke on multiple occasions, and so it's really a pleasure to be able to introduce him this afternoon. He's well known in the nursing administration circles, and we had a wonderful luncheon. The students and I had a wonderful luncheon with him this afternoon, and I promised him that I would not take all of his time in providing his introduction, because with his CV, I could literally take the time of his entire talk to tell you about him. But what you do need to know is he did not start out as a nurse. He really started out with the Baccalaureate of Science in Biochemistry and Nutrition from the University of Ottawa. And then he got a Bachelor of Arts in Psychology. And then he saw the error of his ways, and he decided that he needed to become a nurse, and he achieved a Master of Science degree at the School of Nursing at Mcgill University in Montreal. And anyone who's familiar with Mcgill knows that it's really one of the premier schools in Canada. So that really is a testament to his abilities. And then he went on to get a Doctor of Philosophy, also from Mcgill University in Montreal, with honors. And then that wasn't enough for him, so he decided that he wanted to come to the United States, courtesy of his wife, on a green card, I found out. And he came to the University of Pennsylvania in Philly, and he achieved a postmaster's certificate nurse practitioner certificate with a concentration in cardiology. So he really loves taking care of cardiology patients. That's his background at the time. And then he decided, well, that wasn't enough either. And he decided to really go into the frying pan with the fire full tilt up. And he decided to do a postdoctoral fellowship at the University of Pennsylvania with Dr. Linda Aiken. And I can attest to the fact that Dr. Aiken is a wonderful researcher, but she will put you through your paces when you work with her. So he then proceeded to do a 2-year postdoctoral fellowship with her, and then stayed on to be the director of the center there at the University of Pennsylvania School of Nursing of the Health Services Center that Dr. Aiken runs. And so he told us at lunch that it seemed like his 2-year postdoc became a 9-year postdoc. But then he decided that he really wanted to, he told us at lunch, he really decided that he wanted to merge the administrative issues with the clinical issues in his research. And there at the center at Penn, the Penn School of Nursing, they really work with large databases. And so he wasn't going to be able to do some of the things that he wanted to do in his research area, which you're going to hear about today, if he continued to stay there. So he had an opportunity to go back to Canada, and he is in the inaugural chair of the Royal Bank of Canada Financial Group in cardiovascular nursing. So you see how it comes full circle in going back to his roots in cardiovascular nursing. But he's also an associate professor at the Lawrence Bloomberg faculty in the School of Nursing at the University of Toronto. And he also has a joint appointment with the Peter Monk Cardiac Center at the University Health Network. So that's why you see the different logos on his slides. And then, again, if that wasn't enough, he's the Deputy Director of Nursing Health Services Research Unit at the University of Toronto site. He has, as you can see in your program, he has over 50 publications, and they're consistently cited over and over again. I know I've cited his work many times in some of my articles and my grant applications. So he is one of the foremost researchers in nursing administration and is repeatedly cited. He's sought after as a consultant. He is a consultant both in the United States and Canada, but also internationally, well known in Europe. Consulting with the Belgians, the Dutch, the Swiss on different issues in nursing administration. So I could go on and on. He's a fellow in the American Academy of Nursing, but just know that it's really a rare treat that we have him with us today to talk about his current work And we so appreciate you being here. This is his first trip to Austin. And so as he saw the error of his ways in becoming a nurse later in life, we might yet teach him that he can always become a Texan. You know, there's still room. People come to us later, you know, they see that they can, we will take him, and, you know, you'll just have to listen to that Lyle Lovett song about being a Texan, and I'll get you one of those CDs and you'll understand it later. But please welcome, we're so appreciative of having you here.
Thank you so much. Thank you so much for that kind introduction. So I'm on, and I'm not too loud, because I tend to be a little on the loud side. Thank you so much for that kind introduction, Linda. It's such an honor to be here. It's such an honor to be in the presence of the professor emeritus who the lectureship is named for. Very kind introduction. I thought what I would do today is, as Linda was saying, talk about my current program of research, make a little bit of reference to my history as an investigator, though. Linda gave you a nice oral background. I thought I'd start with a few pictures to sort of guide us in before I start throwing some data at you. This is a picture of Mount Sinai Hospital in Toronto, in downtown Toronto. It's actually called the new Mount Sinai Hospital, and I was born here 43 years ago, and I actually work in a hospital that's right across the street, the Toronto General Hospital, and it's just interesting the way life goes in circles, the way Linda was talking about. When I told one of my colleagues that I was moving from Philadelphia to Toronto and I would be working in the hospital across the street from the one I was born, she said to me, "You're not planning to die there, are you?" No, nothing like that. But it's interesting. What I want you to retain from the talk is that what sort of unites the different threads of my research career is that I've always been interested in context. The things about the places where patients are cared for that influence their outcomes, the nature of nurses' work environments, how these things come together from a practical standpoint, from a leadership standpoint, and I think some of my personal background that I'm going to explain in the next few minutes might explain how I drifted into this area. This is a picture of the apartment buildings in Ottawa. So my parents moved from Toronto to Ottawa when I was just a few months old. Ottawa is the national capital. Washington, D.C. rivals it. But many times in terms of things to do, you can spend days in Washington. You might be able to squeeze 3 hours out of Ottawa. But nothing in my childhood would have foreseen that I would have become a nurse. No nurses in the family. Public servants, though. It's a very political town, Ottawa. I did work for a few years as an office assistant in the agency that did nursing home and chronic hospital placements, though. That's how I worked my way through college. So I guess I had a little bit of a health systems feel during that time. And then, as Linda described, I found the error of my ways and I decided to become a nurse at Mcgill. And this is an interesting shot of Mcgill. Mcgill, for those of you who know Montreal, is right in the heart of the city. So in the foreground there, the building there with the nice cupola, is the logo of Mcgill, actually, is the main administration building. Behind it are other buildings, and right behind that is the Royal Victoria Hospital, which is one of the leading hospitals in the teaching hospital system, which will soon be decommissioned as a hospital, and because they're building a great big brand new facility, hopefully with the right engineering and architecture. So it was a very interesting place to become a nurse because Montreal, Mcgill is a leading English language university known internationally. Montreal is a city that is now 93% French speaking, but with a heavy component of English speakers. So learning to be a nurse is learning to work across languages and across cultures, and that was quite an interesting experience. Here's another view of Mcgill, because Montreal is on an island, right? And so we're looking into the St. Lawrence River from there. It's a sort of a nice view down from, I believe, the main medical building. Now, one thing that was kind of interesting, that was sort of formative, I guess, was the fact that I began nursing school during the longest and most bitter nursing strike in Canadian nursing history. And the nurses were joined by hundreds of thousands of other civil service workers in Quebec. And the interesting thing is that as I was going to register for classes and going to my first lectures and watching the news and hearing the nurses talk about why they were on strike, It was the first time I heard people talking about trying to make sure that working conditions were in place so that nurses could do good work for their patients. And that sort of got planted, I guess, as a seed and got carried over into other experiences that I had. So I was a fairly typical nursing student, maybe more curious than some. I really like nurses as people. I guess there are things about my family background, not coming from a family of nurses, things that really appeal to me about the way nurses look at the world and the way they do their work. So I was a particularly avid student, I guess, and particularly interested in understanding how nurses thought about their work and why they did certain things in certain ways. I was a coronary care unit nurse in one of the teaching hospitals in the Mcgill system, and I did my PhD in a totally different area. I did my PhD with a leading researcher in psychological and social aspects of cardiac disease. And they actually published the groundbreaking papers that found 5-fold increases in mortality after a heart attack among patients who were manifesting symptoms of major depression during that time. So that was an interesting time to be working in a research group. And they were also running a 1,200 patient clinical trial of nursing intervention to decrease psychosocial stress in those patients. And so that's where I cut my teeth as a research assistant. I also started my career, during my PhD, I started my career as an instructor. And that's been sort of a thread that's really influenced the way I look at context of practice. I've been teaching undergraduate nursing for almost as long as I've been a nurse. For the last 10, 12 years, I've been teaching health policy, management, and leadership at the undergraduate level. I love my research. As you'll see, I'm very enthusiastic about what I do. In terms of the lasting contributions to the field and to the public, I think that the education side of things is really critical. And I can tell you from the bottom of my heart that what I see in the classroom and what I hear from my students when they're in school and then when they come back to talk after they've been out in the field influences how I do my work strongly. My first research projects, well, my very first paper is actually with the woman who became my wife a few years later. It was a research brief in the Canadian equivalent of the American Journal of Nursing, and it was actually surveys of nurses in 2 hospitals, so 98, N equals 98 study of nurse job satisfaction and so forth. Who would have thought that 8 years later I would be in Linda Aiken's office discussing the possibility of working on a study of 43,000 nurses in 700 hospitals across 5 countries. I did some qualitative work on process of care in the ICU as part of my master's degree and my PhD dissertation. As you might have guessed from that description, I worked instead of with heart attack patients. In my dissertation, I did some secondary analysis with big data sets of drug trial data to try to understand whether gender, socioeconomic status, ethnicity, and so forth influenced heart failure outcomes. And I have to say, research is an applied art. We get better at it over time. We learn from everything we do, whether we're a subject in a study, a research assistant, or whether we're actually one of the co-investigators or the principal investigator. And these studies, they didn't seem like much at the time, but they sort of laid down a foundation and helped me build some skills that would serve me well later on. So then I went to Penn, and this is a statue of Benjamin Franklin, one of 4 on campus. You can go to the Penn campus and play Where's Ben, like you can play Where's Waldo. Penn was an amazing, amazing experience in terms of the sort of the level of energy, I guess, around the potential of academic nursing. And it was a fantastic experience, both to get the clinical training there and then to work with Linda. Linda described the experience very well, and I do really mean that. It really did feel like 9 years of a postdoc. And in addition to being at Penn doing training and then going on faculty, lived in the city of Philadelphia, which has a different feel than the diversity than you see in Montreal. I came as a Canadian. I think Linda alluded to that too. And I love this cartoon, and so do health services researchers. You seem familiar, yet somehow strange. Are you by any chance Canadian? And health services researchers love this because indeed, Canadians and Americans come from the same home country, the same motherland, but the way the 2 societies have evolved is very interesting and different, yet there's so many similarities. And so when I went to work with a research group that was particularly interested in whether or not the experience of nurses in Pennsylvania would be similar or different to what they were in Alberta and Ontario and Germany and England, it was considered a particular asset that I came with an understanding of a few different systems on the Canadian side. I entered my postdoc in 1999, and for those of you who do patient safety research, you will recognize 1999 as the publication date of To Err is Human, which is probably the watershed moment in this field of research, where the statistic of 60,000 to 100,000 preventable deaths of adults in the United States potentially attributable to medical errors in hospitals. So I came into the research group at Penn just at the time when they had gotten in 43,000 nurses worth of survey data, millions of patients worth of outcomes data, and when everyone all of a sudden was very, very much interested in aspects of context involving staffing, because we were just hitting the current nurse shortage that we're working our way out of, but we're not sure exactly where it stands. So to be a researcher at this time was also, to become a researcher in health outcomes at this time was to become one who is very patient safety focused. And of course, the group, from some of the best known papers that came out of the group at the University of Pennsylvania, included a paper that linked staffing levels in Pennsylvania hospitals to mortality rates for surgical patients within 30 days after admission. And I had the great honor of being the lead data analyst on that paper and of doing the merging of the various data sets and smoothing out the roughness in the data, but keeping us right on track in terms of being publishable in JAMA. And I think one of the things we were most proud of when this paper was accepted in JAMA was the fact that it was considered that a nursing story that we thought was a no-brainer was considered worthy of a publication in a internationally leading general health services journal, I guess. So I enjoyed doing, as Linda was saying, I enjoy doing this work with large data sets very much. And I still mentor students in figuring out the strengths and the weaknesses in the data sets and creative ways of analyzing them. That's still a part of my life. But as she mentioned, I've become increasingly interested in other aspects of context that specifically involve some of the processes of care and things about nursing and nursing care that you can't necessarily identify with large discharged abstract data sets. So this is a skyline of Toronto, and that large building there is the CN Tower, which my son can see from his bedroom window, which is kind of neat. The CN Tower is to Toronto as the Space Needle, I believe, is to Seattle. But it's quite an interesting city. 6 million inhabitants, 3 million in the city. Over 100 different nationalities represented in identifiable communities. Very multilingual, very much a public health epicenter for a lot of incidents. Many of you heard about SARS. We were also a major spot of international attention during the H1N1 crisis. But it was a very interesting place to be continuing my career, I guess. So I have a joint appointment, as Linda mentioned. This is Toronto General Hospital. So in our hospital system that includes a teaching tertiary hospital, a teaching community hospital, and a cancer center, this is the flagship. And it's an institution that's been renovated over the years. And I have an office where I work side by side with the program administrators in the cardiac area. So I get to combine my past and my present, I guess. And I also have an appointment over at the School of Nursing, and this is our building, the former Toronto Board of Education building. Apparently the executive suite for the head of the school board was converted into a whole boardroom when it became ours. But so that's just a little bit of background. So the theme of this talk today, context. One of our greatest Canadian authors, Margaret Atwood, she has a quote from one of her books, "Context is all." And I really believe that in my heart of hearts. Really, it is about context. When we see the range of experiences that patients have, that nurses have, that institutions have, we realize that we start to need to look under the surface for what else is going on. So when I started working with Dr. Aiken, and when I sort of moved from studying how heart failure patients exist and move through care within the context of their clinics and their healthcare system, when I moved over to studying some of the things I'm going to talk about today, I came across this model, which sort of has served as sort of an organizing framework for me. We tend to think about patient care situations, the patient, the nurse, the family, the physician, the other allied health workers and professionals who are involved in care. But care takes place within the context of teams, which is why there's so much emphasis on interprofessional practice right now. It's also occurring in the context of local work unit managers, frontline nurse managers, and managers from other disciplines. Those units, those work units, are existing in the context of organizations that are making decisions about how resources are shared. And then there are issues and forces from the society and the healthcare system at large that are trickling down. And it is normal. It is very normal, natural, reasonable, productive to focus a lot of our energy in healthcare research on that inner box, looking at that patient and that nurse and maybe that physician too. But there is some bang for the buck in going outside that inner box and looking at some of those other elements of context. So this is a diagram that I stuck in a report that I had to issue, trying to explain how all of these different things that I've studied over time relate to each other. And I guess how I would explain, how I would characterize myself as a health services researcher in nursing who's interested in organizational context. But I'm interested at the different levels at which decisions can trickle down and influence that inner box. So I'm interested in the health policy end of things. How do policies in Medicare reimbursement ultimately affect the funding of individual hospital units and the staffing decisions that are made, and in turn, the quality of care that's delivered? And there are many, many other examples, and I'll just touch on a few of them in a second. I'm also very, very much, I would consider myself, I'm honored that Linda would consider me a nursing administration researcher, because that is indeed the tradition that I would place myself in, because I believe that the major consumers of much of the research that we generate is indeed the nurse manager, the middle manager, the nurse executive. And then another level that I operate at, of course, is the level of the individual clinician and the nurse interacting with each other. And so both the processes of nursing care, which, as all of you who are graduate students in nursing administration know, very critical thing, very difficult to get good quality research data about, as well as the outcomes of healthcare from the point of view of different participants and stakeholders in the system. So when we look as organizational researchers at healthcare, what kind of things hit us? Well, one of the elements, many elements about healthcare situations are predictable or standardizable. That's a made-up word there, I guess. But unpredictability is also a constant, right? We never know how the encounters are going to go, how the patients are going to present. We can predict with reasonable accuracy how many patients will come to us because it's a Tuesday morning in July and it's this hospital in this area of the country, but there's always that randomness. Most services have multiple components. It's not just a matter of one provider and one recipient. It's multiple systems, multiple departments, and each have the possibility of error almost engineered into what we do. The delivery systems are very complex, the way they interact with each other. The people involved tend to have their own priorities, and it's not always the outcomes of the patient that are the priority. And the services are often delivered in large numbers and or under time and financial constraints. So you got some good material here to work with if you're going to start to think about this work in organizational context. And you think about nursing work and sort of standing less from the point of view as a fellow nurse and more from the point of view as an organizational researcher. The services are delivered in large volume by several layers or types of workers. And interestingly enough, until recently, we haven't talked about that coordination function very much in research. The articulation of the nature of the work that nurses do has never been all that easy, which gets to be a challenge in a lot of ways, especially when people are asking questions. Do we need this many nurses? Do we need all this many nurses who are educated at this high a level? Do we really need master's prepared nurses for this role and so forth? And we all have sort of a sense of what nursing is, but the various attempts over the years by minds much greater than mine to define what nursing is have never resulted in definitions that make instant sense to the general public or the CFOs or the CEOs of institutions. We have a complicated history as a profession and as a discipline. We're not a discipline that's used to negotiating from a stance of power. And We operate in sort of a yin and yang relationship between this idea that we should be empowering nurses as knowledge workers and this idea that we have this massive amount of work that has these huge safety concerns and that we need to standardize and we need very much a command and control fashion of managing services. So again, there's so much richness here to work with, which is why it's so great to be a nursing administration researcher. And then if we dive down even more, what does acute care nursing look like today? And none of this is going to be a surprise to anybody in the room. Rising patient acuity and intensity of care on hospital units over the past decades, right? It's very tough to get into the hospital. They'll look to get you out as much as you can, as possible. And there's pretty high thresholds for discharge. Get them in sick, send them home sick. And what this means, though, in terms of nursing work, and there are a few excellent scholars in nursing who have been looking at this, the idea that you have this constant motion of very sick patients in and out of hospital units that creates work that very few people outside of the profession really understand, this idea of churn. There have been many researchers, excellent researchers, who have done work about constant interruptions as a feature of nursing work. I think on the low side of the estimates, 6 times an hour at least that a nurse is interrupted in the middle of doing something for one of his or her clients. Overstimulation and sensory overload. Put a noise meter, a sound meter in the average nurse practice setting and you'll be shocked, or maybe you won't be. Documentation burden. The estimates, many of you know the studies that have been done in the Kaiser Permanente system out in California that looked at time motion studies and what acute care hospital nurses are actually doing with their time. And one of the chief findings was that only about 30% or less of nurses' time is actually spent in contact with patients. Where's the time going? In a lot of cases, to documentation and paperwork, which is a whole other issue, and I could talk about this for 3 hours, but you don't want that, is for the most part not fulfilling its function as a communication tool, not enhancing patient safety, and not making our lives as researchers any better. Often in many organizations, I'm sure not here in Texas or particularly here in Austin, but in many of the hospitals that I've had contact with, there are limited formal staff development initiatives, yet the acuity keeps on increasing, and there are so many initiatives out there related to quality and safety, and it seems that not a week goes by when we're asking staff to incorporate yet another kind of innovation disconnected from the others, and it just has to be done and has to be done yesterday. So, the framework that I was sort of initiated into, and this is sort of a reformulation a la Sean, I guess, of the theoretical and conceptual work that guided the work at Penn. Leaders are making decisions in hospitals all the time, hospitals and other healthcare agencies, about human resources, the bodies we're putting on the ground, their qualifications. Some of those decisions they're making explicitly. Sometimes they're dealing with what they can in the particular area given finances and the available people to recruit. But there's a whole category of influences that managers can have, managers and leaders higher up in the chain can have on the quality of nursing practice that goes beyond human resources. And people tend to call these factors the care environment, the practice environment, the work environment. And these are things like the degree to which staff feel supported by managers, the extent to which they feel that resources beyond just another body to provide care, good equipment, good resource nurses, advanced practice nurses and so forth, the extent to which those are available, the quality of relations with physicians and others. Those differences across institutions, who's on the ground, the quality of leadership, ultimately comes down to the influence at what we might pretentiously call the patient-nurse interface, the bedside, the clinical contact point. And we think those things influence patient outcomes in the end. So I'm just repeating myself there, but some of the conclusions that you reach and that you start to understand pretty quickly, it's very hard to have excellent care environments as a manager or to foster them if you don't have enough staff to work with. But excellent staffing or high levels of staffing alone do not guarantee safe outcomes, which is the reason why so many of us who actually do research in the area have some very serious concerns about minimum mandated staffing ratios. And some of, the fact that some of the worst highway accidents and so forth happen on sunny days when there's in plain daylight. some of the worst patient safety disasters have happened at times when staffing was excellent. So we have to go beyond the superficial in terms of numbers and look deeper. And in the end, though, what is the proof in the pudding of the manager's work in establishing human resources and environment for care? It's ultimately going to be about what the quality and quantity of care is that's received on the front lines and what patient outcomes are. So in using that framework, and I'm not going to talk about any of these things today actually, but just to give you a sample, because I've done a whole bunch of things both in collaboration with others and as principal investigator. I've looked at measures of nurses' work environments measured with surveys, at staffing levels of various kinds. I've worked with doctoral students mostly, looking at implicit rationing or prioritizing of nursing care. I've looked at hospital restructuring trends. We had a pretty major dose of that in the 1990s when I first became a nurse, and then I got to study it after experiencing it. Legislated staffing mandates with my colleagues at Penn. We took a look at that. I've even done some work with different colleagues around psychiatric comorbidities in medical surgical settings. And what kinds of outcomes have I looked at in the past? Things that we could get out of secondary databases easily. Things like inpatient and 30-day mortality, which we choose, not because death is not important. I'm not denigrating. We want our patients to be alive and happy and go back to their families in good condition. But the major reason we choose mortality in outcome studies is it's pretty much one of the most reliable data points in a secondary data set. And it's not always correct either. That and the patient's insurance carrier number. We've looked at nurse ratings of quality of care in survey research. We've looked at reported errors and accidents in care. We've looked at patient satisfaction. And as I said, I continue to do work in these areas, generally drawing on large secondary data sets, but I've become very conscious of the fact of what sort of things are left in shadow, if you will, if you only look at the things we can measure easily with surveys and with secondary data. So what I'd like to talk about today is two big areas of very specific, perhaps too specific to be of broad interest, but I'm hoping not. Two particular areas involving safety of nursing practice that I've studied in a particular amount of detail. And one of them is what you might call in a highfalutin fashion, percutaneous injuries with used sharps, or just needle sticks or sticks, and related occupational injuries, which I got into. I'll tell you a brief story about how I got into that. And then I also want to talk to you about rapid identification and rescue of hospitalized patients who go into clinical crisis. What you might call good catches versus a concept known as failure to rescue. And I want to tell you about how the studies that I did evolved over time that relate to those two areas. Needle sticks a little bit. My administrative assistant, Mary Louise, shudders every time she hears the word needle sticks, and so she says, please don't involve me in any part of your work that involves needle sticks. Just the thought, she's not a nurse, the thought just repulses her. So I hope I'm not going to repulse anyone here. People did have a very interesting reaction, though, when I started writing papers in this area. They said, why are you interested in needle sticks? I mean, where's the curiosity there? And, of course, there is a huge occupational health and safety area around this. Bloodborne pathogen transmission, huge deal. And we worry a lot more about hepatitis. HIV is an issue, but it's been a long time since we have a documented case in the United States of a healthcare worker getting HIV through an occupational injury. The numbers, and they're probably down, although I haven't seen much more recent numbers than this, so I can't tell you for a fact. The University of Virginia is an excellent center for needle stick injury research, and they calculated 600,000 a number of years ago of these injuries occurring every year. So it was a major occupational health concern in the late 1980s and early 1990s. And in fact, I got into needle sticks through my mentor, Dr. Aiken, who, in the course of doing some of her research in the early 1990s, did a study funded by the NINR on models of HIV care and whether or not specialized HIV units would be superior to distributing HIV patients all over the hospital and sort of wrapping them into the med-surg population. And I won't go into that a lot. If you want to ask me about that in the question period, or I'll direct you to the papers. But the interesting thing is, and she taught me a lot about successful grant writing, there was an opportunity that the Centers for Disease Control launched for people to piggyback studies of occupational bloodborne pathogen exposure into existing studies. And so she embarked on, to that point, one of the biggest observational studies of needle stick exposures that had ever been done. And by the time I came to work as part of the group, probably about half a dozen graduate students had already turned down the opportunity to work with needle sticks, thinking, ooh, needle sticks, gross. Well, I had worked already with a data set that was a great opportunity. It was a clinical trials data set, but I was thinking, ooh, a data set to work with some well-collected data about any outcome variable. I'm in. So I started, and you'll see where I went with it. Now, in terms of the solutions to this issue, I mean, nurses are always going to need to use sharp instruments to get access to patients in various forms. The two major solutions are, one, to educate staff about handling sharps safely. And I was part of probably the last generation of nurses who didn't have drilled into their heads that they must not recap. They were teaching us to recap back in the late 80s. But the major force that influenced the decline in these injuries was the implementation of specially engineered sharps that reduce the amount of time that a nurse is potentially at risk of injury from a bare sharp. All right. So, again, for why study sharps? Well, because it's an occupational issue for nurses. And for someone interested in safety, though, this is an interesting variable to look at. Because if you ask about needle sticks in an anonymous survey, it's better than looking at self-reported medication errors for a few reasons. One of which is nurses don't always know when they've made a medication error. In fact, that's part of the problem, right? That in a lot of cases, unless after they become students, after they leave being students and they become practicing nurses, they may not know. They may not know unless somebody on a later shift picks up what they've done. And there isn't sort of there is a bit of an emotional tone, I suppose, and there was certainly in the early 1990s around the risks that were involved, but generally speaking, the reporting of a needle stick anonymously in a survey isn't that emotionally loaded. So we had some pretty good reasons to believe that they were accurate reports. They are memorable, they are readily identified, and the reason I got into this was because I thought they were a potential proxy for insights into what might be going on with respect to safety behaviors in hospitals. So I think I sort of, I buried the lead, if you want to put it that way, of the story. You know that needle stick injuries are way, way, way down. Partially as, I would say, a ringing success of advocacy on the part of the American Nurses Association, who did an amazing job to get federal legislation implemented to make sure that safety engineered equipment found its way to the bedsides and the clinics and the home health agencies. But the problem continues, and I just putting in a little public service message about this. This is a number of years old, but I can tell you that it hasn't changed, the situation hasn't changed too much. The proportion of healthcare workers by the early 2000s that were being exposed to Hep C, Hep B, and HIV in any one year, for Canada and the US, under 1%, well under 1%. Look at Africa. 22%, 21% of workers in any given year being exposed to Hep B and HIV. Africa too is sub-Saharan Africa. 1 in 5 healthcare workers being exposed to HIV through a sharps injury in any given year. So it's not over. It's over here in North America and for the most part in Europe, but not elsewhere. And when you look in Eastern Europe, the numbers are considerably higher. And again, because there are some definite safety issues and the diffusion of the technology hasn't been as good. And the estimated proportion of healthcare workers that have Hep C, Hep B, and got it on the job through bloodborne pathogen exposures with needles. In Africa, basically half of the workforce that has Hep B, Hep C got it at work. And this is a really serious issue that people who do workforce planning in those countries talk about, because not only does it discourage people from becoming healthcare providers, but it deprives these countries of a major source. When these folks become sick and become clients of the healthcare system, it deprives those systems of return on investment in a big way in those people's educations. So one of the first papers that I wrote out of the data set that we had with the 43,000 nurses in the 700 hospitals in the 7 countries was some data that showed, in the purple, that German nurses had 3 times the needle stick injury rates in the late 1990s as nurses from Canada, the United States, and the UK. And the question was, why was this the case? Little mystery to solve. And one of the things that we learned pretty quickly going into the data set, we asked ourselves the question, well, is it that German nurses are doing more IV starts and giving more injections and drawing more blood? We went into the data set and we saw that the average American nurse is, so this is the use of safety engineered sharps. I think I took out the slide. Oh, there we go. I skipped over one. American nurses. The average American med-surg nurse is probably starting an IV on her last shift and is doing routine blood draws often. In Canada, the numbers are comparable. In Germany, at that time, nurses didn't do IV starts. Ooh, and they have 3 times the injury rate. And they're doing comparable proportions of blood draws, but IV starts are doctor's work at this point in Germany. So what's the deal and what's going on? So where did we go? We went and we looked at what kind of equipment the nurses were reported using on the job. And in 1999, only less than 10% of German nurses said that that new great engineered equipment that was protecting nurses from having bare sharps in their hands and making them think about recapping, that equipment wasn't used at all in Germany at the time. And in fact, by virtue of collaborating with some folks in German-speaking countries, I learned that the German Hospital Association at the end of the 1990s actually was counseling its member hospitals to refuse to adopt safety engineered equipment because German citizens, German patients don't have bloodborne pathogens. So anyway, that situation changed, and there was an interesting paper that we wrote around that. And the nice thing was that it got to document, as I mentioned, an excellent success story in occupational health advocacy where the US looked good. So in terms, one of the other things we saw, where are the injuries happening in terms of nurses that were having at least one sharps injury in the previous year? The operating room, and you're going to see this come back in some of my later slides. The operating room, a hotbed of these injuries, and an issue that we haven't resolved yet. You look at med-surg and ICU, you look at psychiatry, well, they're not doing a lot of IV starts, but probably more in today's psych units than in previous days. So what did we see? By 1998, 1999, the US has much lower rates than some other countries because of development and marketing and state and federal of safety engineered equipment and some state and federal legislations. Is this evidence for effectiveness of engineering controls? Well, we decided to say it was. But in addition to just describing what the patterns and the rates of the needle stick injuries was, context, you got to know I'm going to come back to context. We also looked at how did the context in the units in the hospitals and various data sets relate to the risk of injury for nurses. So in this particular case, in the inner box, in those nesting boxes, the nurse patients, the patient factors, the situational factors. So for instance, a patient who has a cognitive dysfunction, is thrashing out wildly, is perhaps cognitively impaired, an inexperienced nurse in a code situation, perhaps this would increase the risk that there'd be a percutaneous injury. So we realized that we'd have to take those sorts of factors into consideration, but I was starting to be interested in staffing and in the work environment. And the premise of looking at this was, of course, that perhaps injuries would be more likely under unfavorable organizational conditions that would make people rush, not use safety equipment, not use it properly. So the first paper that I published on this in the American Journal of Public Health back in 2002, we looked at that AIDS data set with 40 units across 20 hospitals, and we saw that the worst staffed units in these hospitals had 2 to 3 times the rates of needle sticks of the other units. And we saw as well that the units that had the worst working environments, the worst working conditions, if you will, also showed 2 to 3 times elevated risk of needle stick injuries during the surveillance period. So this was kind of an interesting finding, that needle sticks and other occupational injuries could be a marker of how well the environment was suited to the provision of nursing care. And so this was a 1991 data set at a time when needle stick rates were very high, that the average rate was about 0.8 injuries per nurse per year. So basically you were likely to have at least 1 injury a year if you were working in a med-surg setting back in 1991. We went back and took a data set from 1998 that was mostly composed of magnet hospitals at that time. We went back and we found the needle stick rate fell, went back and we looked at a number of different variables, including staffing, including work support from managers and staff experience. And we also saw, again, diminished magnitude. It wasn't 2 to 3 times the rate, but it was still 50% to 70% higher risk of injury even those years later. And this work we published in American Journal of Infection Control. We also saw that high technology hospitals that had more use of invasive procedures and equipment, those nurses were at increased risk. Staffing was starting to fade out by that point, so it didn't seem to make a lot of difference whether you had high versus low staffing among those peer hospitals, but work environments did make a difference. The better the work environment, and we could talk about the measure later, but the better the work environment, the lower the risk. So we saw decline in injury risk from 1991 to 1999, and it was all about those great advocacy efforts in the legislation. We saw that staff conditions were really strongly related to Sharp's injury in the initial studies and became less dramatic. And we saw that experience and clinical specialty were important determinants of risk. I got an award from the CDC, the Centers for Disease Control and Prevention, NIOSH, the Occupational Health Division, to do a study of, it started out being 3 states and it wound up being 4 states, 40,000 nurses, again, but all in the US this time. And in the era well past the introduction of the legislation that asked hospitals and other healthcare institutions to pay close attention to equipment and to involve staff in selecting safety engineered equipment. So we were looking at first incidence rates of Sharp's injuries in not only in general hospitals, adult hospitals. I was looking at before. We had a sample in there of specialty in children's hospitals, nursing homes, home health care. We had some practical nurses for the first time in this particular sample in one of the states, as well as advanced practice nurses. And we also wound up getting, in the end, another 150 hospitals in Florida as part of an extension to the study. And what did we find? Well, we found that the rates of injuries with needle sticks is again fairly low. We were looking at one time at 50% to 80% or more of nurses having an injury back in the early 90s. Now we're down to 7, 6, 5%. So the injury rates have gone down further, but they're kind of stuck here. They're kind of stuck at that rate. And because other studies had not considered the distinction between needles, which are handled in certain kinds of nursing procedures, from other kinds of Sharps, we also got some numbers about this. For some reason, Florida looks particularly good, and I can tell you with 40,000 nurses in the sample, it's very statistically significant, and nobody from Florida or for the other states can explain to me. Maybe one of you could, or maybe if I had Texas results to put beside them, you could give me an explanation of what was going on. Now, the interesting thing here is that operating room nurses are still at extremely high rates of injury risk. Florida looks different than everybody else, Florida in the red there, but the other sites, I mean, it's doubled risk, which is very consistent with what other investigators and state departments of health are finding consistently. In fact, there is actually some evidence that suggests that since safety engineered equipment was introduced in the other specialties, the situation has gotten worse in operating rooms with respect to Sharp's safety. So this is uncharted frontier, and people need to work harder. They are doing some work about, for instance, passing instrumentation in the operating room that doesn't involve a handoff the way we used to see in old movies and TV shows. But still, that doesn't seem to work. We're trying to make people mindful of what they're doing in the operating room. Seems like a complex problem. And this is a used Sharp other than a needle. And again, the operating room nurses are off the chart compared to the others. You might ask, what are non-needle injuries? Well, in some instances, there's styluses that are used for doing blood glucose determinations and so forth. But sometimes there are surgical instruments that are used on the regular units. So we didn't see, so I went back and I did those, the boxes version or the line version. Do the staffing decision, do the human resources and the organizational factors relate to the needle stick risk? This time we didn't even see a whiff of any kind of association of staffing with injury risk. There were some, but by far not the majority of organizational factors that showed a bivariate correlation with injury. Generally, nurses who worked in work environments that had worse conditions were at higher Sharp's injury, but only one of the organizational variables came out in the final model. And these are the variables that sort of came out when we controlled for everything. Being an inexperienced nurse within your first 5 years of practice, associated with increased risk. Being a per diem nurse, less hours on the job, fewer procedures, less risk. Interestingly enough, there was an ethnicity connection here where Filipina and Filipino nurses and nurses of self-described Asian backgrounds were at about 80% increased risk. Something that's really not clear, and if any of you have insights into this, I would love to hear, because I've been looking in the literature. Some occupational health nursing researchers have described this pattern of increased injuries. Not sure what that's about. Operating room nurses, four-fold difference in the injury risk. So if anybody is going to concentrate on research in this area, this is where. And then the use of specially engineered devices for IV starts, associated with decreased risk, being in a major teaching hospital, associated with increased risk, all makes sense. And Floridians, Florida nurses, somehow they're fortunate this way. I guess they're dealing with other things. We all have our burdens to carry. Another thing that we saw across settings, because this was one of the first survey-based study of nurse occupational injuries that looked at settings outside hospitals. What we saw was that, as not surprisingly, home health nurses were at comparable, in California looked different than the other states, but home health nurses and nursing home nurses were generally at either comparable or lower risk than the hospital nurses. But one thing that's kind of shocking when you look at the proportion of nurses in these different settings who are actually doing procedures that would imply risk for injury. So 65% of the nurses in hospitals were doing an IV start on their last shift, but only 1.3 in home health, because we have specialty IV therapy teams, and nursing homes 18%, which even strikes me as high. What's going on here with sharp safety in home health and nursing homes when risky procedures are so much less common, and yet the injury rates are comparable or even a little higher in some instances? Again, a little bit of uncharted territory for the next folks to come into. So over time, what we see in this context, practice and risks change, and we see that reflected in the numbers. Have we engineered out most but not all of the problem? And people are asking questions about whether safety engineered devices are actually being used as intended. Is that why we still have that residual 6, 7, 8% annual injury rates going on? Untamed frontiers, the OR and long-term care and home health. Where are the next directions in this area? But it's just an interesting example of how over time, with the same types of data sets in different contexts, was able to accumulate some evidence. Lastly, would like to talk about failure to rescue a little. How are we doing on time? I'm running long, aren't I? Okay. I promise not to go buzzsaw fast, but I know we want to get to some refreshments and some questions. I want to talk about failure to rescue. We were talking this morning about ideas that you hear about for the first time in your practice, or you hear researchers talking about them, and the lights go on. And you talk to other people about these ideas, especially as a nurse researcher who spends so much time in offices and classrooms and in front of a computer. When you talk about an idea and practicing nurses' eyes light up, you know that you might be onto something. You might be onto something. And the first time I heard about failure to rescue, which was a concept developed by Dr. Jeffrey Silber at the University of Pennsylvania, the first time I heard about it, it was explained to me as this measure that we have that tries to get at the quality of care in hospitals by looking not just at the flat rates of mortality among the patient population, but by looking at how good a job hospitals are doing looking after the patients who have complications. Because all patients potentially run the risk of running into complications. What might distinguish a good hospital from an excellent hospital might be what the response is when people deviate off the anticipated path. Dr. Silber, by the way, because I know we're all interested in career trajectories, he's a pediatric oncologist with a PhD from the Wharton School in economics, and he does his research on adult surgical populations, and in addition to being a professor at Wharton and in pediatrics, is also a professor in anesthesiology over there. So it's very interesting how we come into contact, the line runs through, we connect the dots, what will happen? So he actually, as part of his PhD dissertation, here's another one for you PhD students, sometimes you can change the world with your doctoral dissertation, although don't hold yourselves up in working through it, trying to change the world. He developed this measure and figured out a way to try to use discharge abstracts, the information that's passed on to the state health regulators after every patient is discharged, to understand why the patient came in, what secondary diagnoses, in addition to what major procedures the patient had. As a clinician in nursing and a clinical teacher, and also as someone who's really interested in nurses' work and what makes good and great hospitals, I'm interested not only in the measure of failure to rescue, and I have colleagues at Mayo Clinic and at universities around the country who haggle over which diagnosis codes should we include in order to calculate the rate and how should we risk adjust. I'm interested in the concept. The idea of poor outcomes that might be preventable through more timely identification of problems and a better rescue attempt. So surgical patients are a wonderful group to look at. Not so wonderful. I'm not saying surgical complications are wonderful, because they're not. But surgical complications are actually not a bad phenomenon to study. Because there's fairly good data that's available en masse. But if you look across nursing, there are phenomena like this. Think of an incidence where some sort of patient in a mental health psychiatric setting has a behavioral crisis that requires some sort of major takedown and being put into seclusion. Were there any earlier behavioral signs developing that might have enabled an astute clinician to intervene sooner when something less dramatic might have been possible? We were talking over lunch about readmissions of elderly patients and patients who are vulnerable to hospital. In-home health, is there something? Are there early signs, messages that patients are sending us, and they would tell us if they could, but all they can do is give us their presentation, that we would know we needed to get in and do something differently? So I tend to look at this phenomenon, and I've come to look at it in my research as the phenomenon of poor outcomes preventable through earlier detection and treatment of problems. And I really do think it applies across clinical settings. I am actually formally aware of researchers in obstetrics who have been doing work in this area, who've been looking at the management of patients in labor who have non-reassuring fetal heart rate tracings. And I think there's some interesting applications. What have we learned through data set work? And I've been involved in a number of these studies when we look at hundreds of thousands or millions of patient records, and we look at what hospitals have higher mortality rates versus lower ones among their patients who run into complications. Large hospitals, teaching hospitals, high-tech hospitals tend to have better looking failure to rescue rates. Hospitals where staffing seems more reasonable, hospitals where more nurses have a baccalaureate degree as their highest educational standing in nursing. And these are some intriguing things, but we got the structure and we got the outcome on the other side. And the question is, what's happening in the middle? And for those of us who are kind of curious, like the nurse peeking around the corner, who wants to know what's going on here, and from a manager's standpoint, who wants to know how he or she can make the case up the chain why you need more nurses on the ground, it'd be nice to have an explanation about the processes or the mechanisms that are responsible. So I started doing a lot of thinking about this and a fair amount of writing about this, and if you want, I can probably talk your ear off at a future encounter that I have with you around this and send you some articles and discuss till we're both exhausted. But I've done some thinking, and this has sort of moved into some research. When we think about what might be involved here, patient survival following a complication is dependent on the multidisciplinary or interprofessional team coming together. And there's two big parts. There's the watching over the patient part, the surveillance, and then there's the team ability to mobilize resources to bring the patient back from the edge. Sometimes I describe this to students as a car is drifting, without the parking brake on, is drifting slowly down a hill. At the end of the hill, there's a cliff. You know, do we see the car going down so that somebody can jump into the driver's seat and pull on the brake, or does the car go right off the cliff? The rapid response team movement, which I think is fantastic, Institute for Healthcare Improvement, this idea of putting critical care nurses, docs, respiratory therapists on the ground so that a floor nurse who doesn't necessarily have a lot of people present who can help her or him troubleshoot, and we can keep the patients from coding in the first place or get them to the ICU before they have their code where they're more comfortable with that. I think that's fantastic. But the surveillance part is so important too, because we don't know who we could save until we've identified them. The quality of both surveillance and rescue, you're going to see the theme, Context is going to depend on staffing levels and the match between staffing, competencies, and patient needs, and it's going to depend on the quality of the practice environment. So diagrammatically, if we want to look at this, break those two parts out, looking at surveillance. And I have to say, outside audiences like this, composed of people who are focused on nursing or practicing nurses, nurse educators, or are very interested in nursing affairs, generally most other health professions don't understand what nurses do when they are monitoring patients. They don't understand necessarily the level of expertise and the intensity of mental effort that's required to do this well. The information you have to have in order to monitor patients well, right? You ask a patient, an undergraduate patient on a clinical rotation about their patients that they have on this particular shift, and you ask them what their plan is. And often they'll say, I'm going to monitor this patient. And you as the instructor say, that's wonderful. I think that's a great plan. But what are you going to monitor and why? And what are you most concerned about? And what would your action plan be if this happened and so forth? There's got to be some detailed knowledge that that nurse has about the patient's conditions, the most common complications they could run into, the highest risk complications. And there has to be some knowledge of how you'd connect the dots between the vital signs or the patient complaints or whatever other observations with that. That's information, and I put the bar very high for an undergraduate nursing student still learning the basics of practice. That's why we don't leave students alone or new graduates alone. But that information takes a while to sink in and operationalize. And you have to figure out how often you're going to observe parameters. And then you have to have sufficient staffing to be able to implement your plan. A case that I sometimes talk about with clinical audiences and audiences of managers from the United Kingdom, a patient died of hemorrhagic shock, on a nursing unit fresh out of the operating room after a hysterectomy on a unit that had one registered nurse for 20 postoperative patients. There's no way, unless that nurse is taking some high-intensity stimulants and is on roller skates, that she would have been able to cover that number of patients to observe that patient sufficiently to make sure that didn't happen. So the staffing comes in there. So we got the human resources, the quality of the bodies, and the ability to implement the plan. And the thing is, our patients' conditions are always dynamic and changing. So the patient on day 1 is going to have different risks than the patient at day 4. And we need to have that knowledge at our fingertips. And that doesn't happen by accident, and it really is only by virtue of having managers in place that are thinking about the constellation of staff that they have in place and how to develop them that you're going to get there. The rescue part, the all of the king's horses and all of the king's men part, where the rapid response team comes in, and I have friends who are rapid response team nurses, and they love coming down onto the floors, kind of, I guess outside Texas it might sound different, sort of cowboys and cowgirls. We're going to fix this. In the ICU, I got to wait for a doc's order. Here, I'm going to go intervene and function independently. But there's a lot of knowledge that's necessary for that bedside clinician before the RRT arrives in terms of establishing immediate priorities, in terms of putting together a story involving those observations that mobilizes the rest of the team. One of my sort of paradigm examples of the importance of interprofessional relations as part of work environment, hospitals of my acquaintance that shall remain unnamed, where nurses working at 3 in the morning with a patient who's crashing can't get the attending to come in from home to deal with the unfolding patient situation. That's an issue around communication. That's an issue around interprofessional relations, and the extent to which managers work to resolve those problems and fix them is going to be an indication of their strength as leaders. The whole business of informing other clinicians and collaborating together to make this stuff happen. And it's not going to happen on its own, is the bottom line. And the resources to make this happen, make it possible, especially in situations where some of these emergencies may be pretty uncommon. There's a fair amount of forethought that's involved. So I work with folks on rapid response team projects, but I'm really interested in going back to some of the stuff that's going on with respect to the knowledge work that nurses are doing around surveillance. So, as any good researcher does, I went on the search when I arrived in Toronto for some project money, knowing that our national health funding agency, comparable to NIH, would never fund an exploratory study for tool development to look at nurses' thought processes around the use of clinical cues. I went instead to the MOH LTC, which is the Ministry of Health and Long-Term Care in Ontario, and that funded me to do a study for 2 years that involved probing that business of using the data, assuming there's sufficient staff around to monitor the patients, to actually take the vital signs and not fake them, and so forth, assuming those data are real, to figure out what's going on as a first step to see, for instance, are there ways we can enhance the development of this skill of assembling the knowledge and so forth. So we decided to put a project in, and I got funded for it, to describe the domain of practice that relates to gathering the data and making sense of it by nurses at various experience levels, and to develop a workable assessment tool. Now, my motivation as a researcher, I want to do research. I want to do hypothesis testing studies. I was going to a government agency that as priority number 10 of its 10 top priorities for funding that year was assessing and enhancing the quality of Ontario's health professions graduates. So I spun a failure to rescue project into a service-based project, and I said, you know what, I'm going to put this in the public domain afterwards, this tool that we develop. Let us do this because I think this fits well. So, process that we're finishing now involves gathering data, not just going through the exercise that nursing instructors for millennia have done, assembling multiple choice questions based on hypothetical patients that they might come up with. You have Mrs. A, who is 3 days post-operative after such and such a surgery, and these are her vital signs and so forth. But by going after real data on patients who either had codes or emergency calls, and getting some data on patients who were admitted for the same reasons, in the same age range, on the same unit, who didn't have similar problems, to get a base of clinical observations that would allow us to start probing how nurses are thinking about the information. And what we did at the same time was we took some of that information and we brought groups of nurses together to talk about cases. So we showed them some of those data and we got discussions going. And I'm going to tell you a little bit about what we found. So we are still trying to work. Now, unlike the NIH, which releases its money, when you're funded, you're funded. The Ontario Ministry of Health and Long-Term Care is a little slow on telling you when you're funded, a little slow on releasing money. So we are still finishing out pilot testing, the test format, and we're hoping to go lots of places with this. We're starting paper and pencil, we're hoping to go computerized, and we're hoping to expand this to other domains of clinical practice. So, I was telling you about the cases and the controls. We got about 180 cases of cardiac arrest, and about 2/3 of those 180 cases, we managed to find patients who were matches to them. What did we find in the abstraction? We found the documentation was pretty bad, as you can imagine. There was very patchy documentation of vital signs. Those of you who have had contact with medical legal liability and malpractice cases, you know that the first job of the nurse expert witness for the plaintiff is to go in and make a line chart and to go through, okay, so this patient was post-op what? Okay, so the standard of care is vital signs every 15 minutes, then every hour, then every 4 hours, and so forth. So how many of those were actually documented in the chart? I can tell you that our flow sheets are mostly blank here. And the respiratory rates, very poorly documented. I wrote an editorial with a colleague of mine who's working with me on the study about respiratory rates, which is material for another conversation on another day. The clinical observations, pretty inconsistent too. The quality of the narrative documentation, not so hot. We did focus groups in what people sarcastically call the Mecca, our downtown tertiary quaternary teaching hospital. But we also went to the suburbs, and we went out to a rural area. We did 90-minute focus groups. We presented case scenarios with a bullet of the case, a set of vital signs, and then we got a read on the case, and then we would give them more information, and have them revisit the case, and they would rate instability, and we'd ask them to think out loud and bounce ideas off of each other. Mostly about 8 nurses in the groups. 8 cases got discussed. The discussions were started in different places, so everybody got to talk. We tried to keep the inexperienced nurses together with the inexperienced nurses, the experienced with the experienced. And we gave them cases like this. And these were taken straight from the records. The guy's name wasn't Mr. G. And his age, I think, he had a specific age. He was just in his late 60s. He had a specific age. But this was a guy, renal failure and congestive heart failure, and this was the presentation. And we used the exact words from the chart. And sometimes the observations are kind of interesting, aren't they? But often when you take report on a patient, you get what you get, right? From the Cardex or from report from your colleague, and it can be very informative or not so informative, and a set of vital signs. And we'd ask, on a scale of 1 to 10, how unstable is this patient if 10 is the highest? What did we find? The tone of the discussions was basically exactly the same. If you listen to the recordings in the big city hospital, in the rural hospital, in the community hospital, same discussions. Same, and I would say generally high quality discussions. These nurses, they wanted more cases. And they wanted to know what happened with the cases, which we couldn't tell them, of course, because that wasn't the point of the study. But it was very interesting that it was basically the same substantive content of the discussions across the board. The new graduates were a little more hesitant, as we would have expected. You know, they were sort of, they tended to say 5, 6. You know, they couldn't exactly tell you why. I'm not totally comfortable, but I don't exactly know why. And they would say, I would closely monitor this patient the way we were talking before, but they would not be great on the specifics, which is understandable. Nothing wrong with that. Some interesting things, though, that we found. We went around the room and started the case discussions at different points. And sometimes we did have a few nurses that were willing to say, 2, are you kidding? That's a 9, or vice versa. But most of the time, whoever started the discussion, that's how the rest of the discussion went. And even when we would add more information, and sometimes very shocking information, the tendency to stick with the original judgment and to agree with the colleagues was so strong. And we do encourage nurses of any experience level to rely on their colleagues. Check in with them, you know, like, can you come in and see this lady? I'm just not sure how things are going. But you know what? If you don't go in with fresh eyes, and if there's social determinants there, now this is qualitative focus group material, but you could test this in a lab setting. You could do the equivalent of the Solomon-Asch line studies, you know, the ones where which line is taller, and you know, somebody says B, and the poor person who's the Confederate, the Confederates are all saying an answer that's totally wrong, and then there's your subject who's looking around and thinking they need to get their eyeglasses changed, and they decide to just go along with the flow. Missed cues, it was striking. I mean, one of the things that we thought going in is that we would see a fairly high level of background knowledge about what normal values were from vital signs and what the significance of different clinical observations were. In a lot of cases, won't come as any surprise, the crashes or near crashes were about hemorrhage. I'm almost done. Respiratory compromise, blood loss. But the seriousness of the situations didn't sink in a distressing number of the cases. And I mean, blood gases, many of us outside ICUs don't use them on a regular basis, but a set of blood gases that would make an ICU nurse's hair turn white, and they were like, oh, that's about a 5. You know, a patient who is obviously ready to crash, needed to be intubated right then, needed an ICU bed now. So maybe we're making some assumptions about where people's knowledge levels are sitting that aren't too appropriate. And another interesting thing is there were people who said, why do you care about that background information? Because we also presented information about the patient's self-reported status and how they slept and what they were eating and what meds they were on and what the history was. And there are people who are saying, no, you know, just give them vital signs, because vital signs are all that counts. And in the end, what we found was that the nurses, for the most part, were not using any of that other background information. They were using it to confirm their initial impressions that either the patient was stable or was not stable. So this is sort of interesting stuff, and this is why you have to be open to the possibilities of what your data will unfold. There's lots of hypothesis generation out of here that can be tested in more detail. So where are we going? Well, we're hoping that we're going to do sort of comparisons, you know, circle or rate the severity of these cases, circle the most pertinent findings for a particular case, and then, you know, which of these patients would you see first if you give these current shift, previous shift, and so forth, and maybe even ranking the priority of 4 different patients. So we're cleaning up the data set, and we're going to field test this in the next months. Now again, I'm looking at that inner box, but we need to understand that inner box before we can start to understand the impact of human resources or staff development or any of those other things. So what do managers do in healthcare settings? They're making decisions about human resources. We talk about ratios and staff coverage measures, how many bodies on the ground, how dense the nurses are on the floor in the clinic. We look at staff mix. There are other decisions, though, that need to be made about care delivery models, about how exactly work is going to be distributed across the various nurses, and which registered nurses are going to look after which patients, and who's going to be responsible and accountable for various elements of care. And then we have this whole business of practice environments. We were talking about how the responsibilities of being a frontline manager in healthcare are just so enormous. I think, any more than a casual glance at, only 2 of these sorts of very frontline micro practice issues sort of indicates that. So sometimes in consultations that I've done, I talk with folks about what I believe are the preconditions to get to safe patient-centered care in healthcare institutions. And definitely having a sufficient critical mass of properly educated workers who know what they're doing, that's the base. But that's only the beginning. Because people have to know what the priorities are and what they're really supposed to be doing. And sometimes we all think we're on the same page, but we're not. We need resources that when we find that we're not doing the right things, we need the people and the time and the patience, frankly, to do the changes. And we also need ongoing measurement, especially for things that aren't obvious up front. My wife is a wound care nurse. Pressure ulcers are her life. You can ask my 10-year-old and my 13-year-old. I think pressure ulcers are very important. Thank you very much. But I also think there are other elements of nurses' practice other than falls and pressure ulcers we need to look at. What makes management practice so interesting, you can see here probably not a well-lit slide, dog with a torn copy of Dog Training for Dummies on the ground. We think that we're going to get certain results when we manage healthcare settings in certain ways. But the beauty and the challenge and the hair-pulling frustration is that often we don't get intended consequences out of some of our actions, and it's because of the complexity and the context that we get there. And the very last slide. This slide I saw 10 years ago. It's a painting by an American artist named Benjamin Edwards called Convergence, 2001. And it is Mr. Edwards' portrait of America at the turn of the millennium. It's his representation. Now, what is this? He went around the Washington, D.C. area with a camera at a 20-mile radius from the geographic center of the city and went around through Maryland, Virginia, and the outlying area and took pictures of the landscape that he saw. Simplified them into acrylic paintings that he overlaid on top of each other, overlaid them together, and that's what he got. And he thought, and maybe you're going to disagree, but he thought he was giving his impression of what America at the turn of the millennium was looking like in terms of what's in the middle, what's in the top, what's on the ground. When I saw this, though, I thought, wow, this is outcomes research. This is so much outcomes research, nursing administration research, because to the outsider, it just seems way too complicated, that thicket of white and yellow and red and black and all those shapes and so forth. But there are patterns underneath all of it. And so our challenge as clinicians and as leaders trying to make healthcare safer is to find that context, to find those consistencies at the various levels, to pull them together as a whole to give our patients the best quality of care possible. So thank you very much for your attention through a very long talk. You were such a polite audience, nodding and smiling, that I just kept going. So I thank you for that. I would love to take questions if you had them. And you're free to disagree with me. Having taught undergraduates for 15 years, I'm pretty much ready for anything in a lecture hall setting. So, any thoughts, disagreements? Yes.
I'm Shannon Patton. I work in simulation School of Nursing. And when you were talking about where you were having your focus groups and trying to identify what elements they were responding to besides vital signs, and I thought, wow, we do this in simulation, or we could set it up in simulation where we're trying to sensitize them to more elements in context than just the vital signs. And I wondered if anybody else had thought of that.
Well, I think it's an amazing point, because I think it needs to be studied. I mean, presumably the reason why we take people through a 4-year baccalaureate education, we insist that they have a foundation in the humanities and the social and the natural sciences and so forth, and we educate people so thoroughly in a clinical method that emphasizes basing practice decisions on data. You'd hope that they would use information in a sort of a logical way. But I think we don't know a lot about this. I think think we work on assumptions. And sometimes, work like Patricia Benner's work, that talks about exemplars of excellent clinicians, you see everything crystallizing beautifully where people sort of can connect the dots sort of in a post hoc manner. But I think we need to know more about how this process works, and I absolutely think it would be well suited to research with simulation on the ground. I read an interesting report from a group of researchers commissioned by the province of Alberta, where they've been doing some pretty heavy-duty stuff, increasing the proportion of practical nurses or vocational nurses in their staff mixes, but that compared nurses with different kinds of preparation. The registered nurse, what they call the registered psychiatric nurse, who has a lot of specific training in mental health, but very light med-surg training, and practical nurses, and putting them side by side and asking them, actually not side by side, in different rooms at different times, and asking them to talk about case materials. Unfortunately, they didn't share the case materials. The message that in the report was, well, the baccalaureate educated registered nurses, they just gave so much richer descriptions, and they showed the breadth of their preparation and so forth. And the practical nurses seemed to follow a template in terms of the data they collected and how they analyzed the data. But then you went further. That was the message that most of the people took from it. But you go into the report and you start to read. And you read that, yes, those baccalaureate educated nurses in that Alberta sample, who might have been under some very particular demand elements of the situation where they felt they were expected to say certain things, but that, yeah, they had tons of conjecture to offer. Tons of conjecture about connecting the dots that had nothing to do with the clinical management that was in front of them. And that the practical nurses, in fact, yes, they came from programs that are now 2 years at the community college level in that particular province. And yes, they were taught a very systematic troubleshooting method for working through the collection and analysis of data. And yes, it did feel like they were working through a process, but they were quite a bit more parsimonious in coming to their plan of care and generally hit on the right stuff. Now, I've been a baccalaureate educator for almost 20 years, and I know you guys, you went to one of the premier programs in the country. I'm not denigrating baccalaureate education at all. Au contraire, as we'd say in French. But I think there's some questions to be asked about clinical judgment and about the way we develop it, because it's all fine and well to enable our students to have great conceptual discussions, but if they are not so comfortable making on-the-ground decisions about prioritization and feeling confident and expressing those in a confident manner, then I think we're selling them and the public short in terms of what they should be delivering. So I would love to talk with you. I mean, you should pursue it. You don't need me. You have the ideas, but if you'd love to collaborate, I'd love to share the materials I'm developing or talk about ways we could work together. Yeah.
If you look at the operating room needle stick or instrument stick data, operating nurses, room nurses do different things, circulators, they separate those data out and see if there was a differential among the tasks that people were doing.
I think that's an excellent point that you're making, because in terms of the organization of work in operating rooms, there are some very different roles in there. I can say, though, that it seems as if the rates of injury are genuinely high regardless of role. They are a mash. They are it's the mushy gray of all of these different kinds of nurses mixed together. But I believe, though, that nurses who are playing quite different roles are still, because of the way sharps are handled in general and what the culture around this is like, even if the contact is casual, it's still higher, much, much, much higher than you'd expect, given that, for instance, these nurses are not doing IV starts, generally speaking, down there, and they're not doing blood draws with bare sharps. There is something that needs to be attended to. But I can tell you that there are even though it's a huge problem and it stands out in a very clear way, I think that despite for hepatitis C, as you know, the consequences for nurses and physicians and others who contract hepatitis C through occupational injuries are incredibly severe. Healthcare costs are through the roof. The impact on quality of life is horrendous. It amazes me there are not more researchers that are looking at that particular setting so that they can make some finer distinctions. I absolutely agree with you. We're not paying attention to some very important distinctions that are there, ones that we really can't make given the nature of the data set, though. Yeah.
resonated with me, because my research originated with the concept of the difficult patient, which is often situated in the patient. Of course, I'm interested in psychiatric comorbidities of that patient that make them difficult. But actually, I came up with my own diagram that looked at patient characteristics, or patient factors, nurse factors within an environment that may all contribute to that difficulty, which seems similar to the concepts you were sharing.
Right, right. And I mean, there's so much room to explore some of these things. I mean, we didn't even get into the whole discussion of the culture of practice on a unit and the way, for instance, that a mental health patient, we were talking about this at lunch, a mental health patient coming onto a medical surgical unit, depending on what the experience of the staff has been in the past, that may be the patient that we dump onto the nurse who's floating, or the agency nurse. That may be the patient that we give to the staff member that we're trying to, that we believe should be carrying her share a little more. And there may also be culture around the way that patient fits within the priorities of the unit and what constitutes good care. So there are many ways of looking at this, and I agree that that's a really fruitful way to proceed.
Thank you.
Thank you. Thank you.
And we have a little present for Dr. Clarke.
Thank you. I may open it.
You can open it? Yeah.
Oh,
I
thank
guess
you.
Oh, look, and it goes with this orange wire.
And
I'll be your assistant here.
Ah.
This is for your weather, I think.
There we are. Thank you. Wonderful.
I don't think you'll be needing that here this
No,
weekend.
no,
but
I don't think so.
Thank you all. I know Dr. Clarke will be glad to share more with you. We have a nice reception outside in the foyer that we welcome you all to stay and visit. And again, thank you, Dr. Gallman, for joining us today for the lecture. We're so delighted to have you. Okay. Thank you.
Thank you.